Those are Tahoe.
Hi everyone.
They're more expensive.
What is the most
Okay, everyone, we will get started. So, close that. So welcome again. Thank you everyone for coming on a Friday. Thank me for coming as well.
Thank you, Taha.
Thank you, Taha.
So today we're just going to continue on with the paper that we started last week. So today is going to be Psych. And yeah, some of the questions are a bit, as always, I've tried my best. So we'll get started right away because actually I think there's a fair bit to get through. I'm sorry, Jess. Okay, first question. So we have Alex, who's relatively old. He's 75 years old, arguing repeatedly with his daughter over minor missing items that he feels she must have taken. He can't understand why she would do this. Okay, so does someone mind getting the door, please? So first of all, let's just because I'm going to keep this simple question simple just so we can get through everything. What do you think he has? Persecutory delusions. Where is it? That one. Okay. So next one.
Yes.
So again, the male, relatively a bit younger, agitated, complains that his skin is crawling about 12 hours after having emergency surgery on a fracture. What do you think he has? Tactile hallucination. Okay, so a common scenario where this might happen, for example, would be an alcohol withdrawal. So somebody who's having not necessarily delirium tremors, but someone who's withdrawing for alcohol, they can have hallucinations, which is usually a maximum of 72 hours. But of the hallucinations that they can have and of the symptoms that they can have, they often complain of something called formication, where they have this sensation of ants crawling across their skin. Formication with an N. Okay, so it could be related. Who knows? Next question. So we have a female. She's 19 years old. She feels that a family member, when she's getting picked up, that she sees someone hiding in the shadows. What is this? Illusions. Okay. So what differs an illusion from an hallucination? It's correctable. Okay. So it's usually it's not due to anything incorrect in your perception, but it's something that you see, for example, the shadows, and you feel like somebody is there. But importantly, it's correctable. Oh, no, it's frozen. Just wait. So my computer's struggling. 1 second. You put it on best performance. Okay, so as you can see, I had too much time on my hand. So, okay, so how do you define delusion? Tell us. So what are the essential parts to define the delusion? What do you need? Sure, let's specify. A fixed false belief that?
It's out of character for their
Yes, okay, good. So that's how you define a delusion. And the other part that we didn't mention is, despite strong conflicting evidence to the otherwise, it doesn't change what they believe in. That's what makes it a delusion versus an overvalued idea. So we'll talk about that soon, actually, it's in there. Okay, so the only reason I put it in here, so this is directly from DSM, is talking about the types of delusions that you can have. So delusions can have themes, and that's what we refer to when we say type of delusion. So for example, first one we have persecutory delusion. So the one that we saw in this question, so how do we know it's persecutory? So he believes that he's going to be harmed or harassed or so forth by an individual, and it's also the most common type of delusion. Especially if you note his age, he was 76 years old in that question, which makes schizophrenia, first of all, a very unlikely diagnosis in that age group. But you can have hallucinations that are associated with things like Alzheimer's disease. You can have late onset schizophrenia. And in those cases, it would be more logical that the hallucination that the delusion that they get is the most common one, which in his case was persecutory. Okay, so referential delusion. So these are also called ideas of reference sometimes. So let's say I'm watching a TV show and I'm watching Grey's Anatomy, and I think that whenever they say a certain phrase on the TV, they're actually referring to me. So that would be an idea of reference. Oh, I'm gonna get my charger. Oh, I don't have my charger. So grandiose delusions. So when you believe you have some kind of exceptional ability. So a common example of this would be if you feel like you're God. So I was actually just listening to a podcast as I was driving over here, and it was a person. Oh, thank you. And it was a person who believed that they were God. And I'll tell you that story a bit later in the presentation. We'll leave it there for the moment. Thank you, Jasmine. Okay. Next type of delusion we have erotomanic or erotomanic. Okay, so this is often when people believe celebrities actually love them, and it's lagging so bad. Nihilistic, so less common, but when you believe the world's gonna magic catastrophe will occur. Okay. Somatic delusions. So what we had in one of those questions.
How would you ask someone?
I think that if you watch a video of something that's erotomanic, you ask them about their relationships, if there's somebody that they're particularly interested in, they'll often be the ones to tell you first. This man's lagging so hard. Sorry, my computer's just going slow. Not sure what I can do about that. I just came all at once. Okay, so if we go to DSM and we try to, and another description that it has is comparing bizarre delusions versus non-bizarre delusions. So bizarre is something that is completely doesn't make any sense. So for example, when you think that somebody is taking my organs out without leaving any scars on my body, so that'd be a bizarre delusion. Whereas a non-bizarre delusion is something that is more logical. So for example, I'm under surveillance by the police. The reason that's an important distinction to make is something like Alzheimer's or dementia has non-bizarre delusions, whereas something like schizophrenia is more likely to have bizarre delusions. And then the last one, as I was alluding to before, an overvalued idea differs from a delusion depending on how strong their belief actually is. So a delusion is never going to be correctable because it's an organic disorder of the brain. Whereas an overvalued idea, with enough time or persistence, you might be able to change their mind about that. But it can be hard to make that distinction. So then going to hallucinations. So I think it's really important to actually know what the definition for a hallucination is. Okay, so it's a perception-like experience that occurs without an external stimulus. Okay, so that's what makes it different sort of from an illusion. How we had the shadow and then you misidentified that as a person. Whereas in the hallucination, you don't have that kind of external stimulus that happens out of nowhere. The other important thing is that it's very vivid and clear. This is why somebody who has a hallucination believes it very firmly, okay? So if somebody starts to hear that they're God, that they have these kind of auditory hallucinations, they will then try to change their mentation and change the life around them to fill in the gaps to make that true, because they fully believe that. So they will actively try to change different parts of their thinking and different parts of their life to try and fulfill what they're hearing in their auditory or visual hallucinations. So that's how strongly and firmly they hold on to it. Okay, then most common is auditory. I haven't got visual in there. And then I've just put this in here for interest. So hypnagogic and hypnopompic hallucinations are considered normal. They are not part of schizophrenia or any other psychotic disorder. So the difference between them is either before you sleep or after you sleep. So hypnagogic is before you sleep, and hypnopompic is after you wake up. Okay, so moving on. Next question. Okay, so we have a 32-year-old woman. She felt like she was on top of the world, full of smiles, bubbly and carefree. And she said that she's only felt like this for the past few weeks. So what would that be? First of all, is this affect or mood? That's clearly mood. And what would you describe the mood as? Euphoric, okay? So more or less pretty clear cut. So a good way to think about it is much like the weather. So if you ever have difficulty conceptualizing what we mean by mood and affect, think of it like the weather and the season. So the weather on the actual day will be the affect of the person, whereas the season of that time of the year will be the person's mood. So for example, in spring, or let's say summer, it's usually hot, but on one day of summer, it might be a rainy day. So that's the difference between mood and affect. Okay, now moving on to the next question. This one is a bit more difficult, but that's why it's an important question. So we have it's not middle ages, it's a young man, impatient at the delay at ED, okay? That's an important to note. He's in the emergency department, so it's in a medical setting. He comes to triage and says in a loud voice, he wants to know who is making the decisions, about who is seen first, what their name is, and I want to see a manager right now. Okay,
Sounds like my father.
so because I think this is a difficult question to answer, we're going to go through the list one by one. I'm just going to decrease it. Okay, so first of all, what is an autochthonous delusion? So another term for it is a primary delusion, which means that it's not secondary to something. When I say secondary, what am I talking about? I'm talking about a delusional mood or delusional perception. And I'll go into that shortly because there's more information on the next slide. What's a clang association? Yeah, rhyming, so pathological rhyming. If anybody has seen Naruto Shippuden, has anybody seen Naruto Shippuden? No? Okay. What is flight of ideas?
It's like going from one thing to the other with some sorts.
Yes, small association. Loose association? Yeah, but importantly, loose association is also an umbrella term, more or less, for three different things. What are they? Anybody there? I need to make sure. I'll wait until the next slide. Okay. What is a metonym?
It's a part for a whole.
Say
No,
again.
it literally is. It's a part for a whole, right? Or is it a snake?
It's the word they represent.
Yeah, it's a part for a whole.
What are you saying? A part for a
It's a part for a whole. A part for a whole. So, for example, this is what we call it when we did Latin. It's like if you have a ship and you're on the deck of the ship, you say deck, but you actually mean the ship.
Okay, but that's a reasonable example. So another way to think about it is like an approximation. So let's say I want to describe a cat to you. So instead of telling you, hey, look, there's a cat over there, I'll say there's a fluffy mammal that meows a lot of the time. So it's an approximation for a word. So keep that in your mind for a moment. What is a neologism? It's a new word. What's a nihilistic delusion? Talked about it before. Or we've talked about those. What's pressure of speech? Okay. So from that list, what do you think is most likely? Okay, we're going to come back to it. Okay, we'll go through this list properly. So the next 3 slides are about thought disorder. Now, usually the only proper term in this condition is a formal thought disorder, but I thought it'd be interesting, or I thought it'd be a good idea to break down thought into 3 different sections. Okay, which is the only reason that hyphen is there. Otherwise, the proper term is formal thought disorder. So that is the impaired capacity to sustain coherent discourse that occurs in the written or spoken language. Okay, so it's a disorder of your thought form. And that's what formal thought disorder means. Okay, so there's many things that is included in that. Okay, poverty of speech. We won't go through all of those. You might know a lot of those. So tangentiality, derailment. So as you were saying before, a lot of these come under the heading of loosening of associations. So loosening of associations is important to know because it's more or less a continuum. So it occurs mostly in schizophrenia. 3 kinds have been described. So the first one is night move thinking or derailment, a lot of people call it. So that's where you have these odd tangential associations between things. So instead of it being a linear association, so I say cat and dog, instead I say cat and something tangential. Okay. See, it's hard. Then the next one, I actually didn't know this, is called talking past the point or voorbeelden. So that's when the patient seems to get close to the point of discussion. So what they wanted to tell you, but skirts around it and never actually reaches what they were actually trying to say in the first place. Okay?
Wait, isn't that psychology about?
To an extent, but tangentiality, you still get to the point and then you go into a different topic.
No, sorry. Circumstantiality.
It's a little bit different, but I don't know how.
Okay.
Okay.
What was that thing you said again? Was it?
VORBEIREDEN. So that's called talking past the point, or at least what I was trying to find. And then the last one is verbigeration or word salad. Some of you might have heard of. So that's when the speech is reduced to a point where it's just senseless repetition of sounds and phrases and different kinds of words that makes no sense. So that is definitely a disorder of thought form, as you can understand. Okay, so other disorders of thought form, we have clanging, as we talked about, we have metonyms, so word approximations. So I'll let you guys read the rest of that in your own time. Then if we have a thought disorder about the content of our thoughts, that's called a delusion. Okay, and then the last one is disorder of our thought stream. So the only reason I've broken it down like this is because I believe it'll make it easier at the very least to help you conceptualize an MSE and what we actually mean when we're talking about thought. Okay, so flight of ideas and these different kinds of things. So what I think the answer is, and what a few people I talk to think the answer is a metonym. So the reason for that, if we look at this person's speech, first of all, more or less, it feels pretty normal, right? That this person is just getting frustrated and they're going up to the desk and they're voicing their frustrations. So the only reason metonym makes the most sense here is because it's the only one that fits. The reason it fits is if we look at this word, okay? He's in an emergency department and you can tell that he's cognizantly aware of what an ED does because he knows that they have to wait. He wants to know who's in charge of waiting, and then he refers to them as a manager. So in this case, you could argue that manager has been used as an approximation for doctor or whoever is supervising or whoever is there to supervise all of these people, which is why metonym, rather than anything else, makes the most sense. Other than just ruling out the other options, that might be the best answer.
Can I put forward, probably incorrect, but still not. Just based on the fact that we asked 3 questions that are sort of closely related and sort of make sense in order, and given that it's a loud voice, could you not pick flight of ideas and what potential meaning?
I just feel like there's much there to substantiate that. Because a metonym also is something that can just happen in English.
But there's 3 different ideas. He's asking about the patient that's next to the line. Then he's asking about the name of that patient, and then he's.
But these ideas are all connected.
Can you agree that that's
I wouldn't say so. Even though there's flight of ideas, you need multiple ideas. And flight of ideas also, so if we go back to it, that's the disorder of your thought stream, right? It moves quickly from one idea to another, whereas in this case, all of the ideas are connected together, okay? So the definition of a flight of ideas is that one train of thought is not carried to completion. Whereas in this case, he's carrying that idea to completion. The fact that he's impatient, that he's unhappy with what's happening in the ED, and he wants to speak to who is in charge. So he's completed that train of thought. Whereas a flight of idea, you wouldn't be able to do that. Okay? So the other thing about this is the same podcast that I was listening to in the car, very like I was listening to it. So they were saying how subtly sometimes psychosis can present. So somebody who has schizophrenia, especially in this young age group, young males that are at higher risk than other people, that psychosis can present in these subtle ways. That you suddenly have these loud outbursts, that you become aggressive, whether that be verbally or physically. And it seems in this case, we have a few things that could fit, which is why I can't definitively say, but I feel like metonym probably is the best answer. Okay. Swords, no, scales and sword and scale. Sword and scale, episode 1. Okay, and then they cut out halfway for some reason. Okay. Okay, we have Maria. She's age 57. And she tells you how she's so excited to be visiting her relatives in Italy next week. She becomes angry at her son when he points out that she has no ticket, her passport is expired, but she doesn't care about that because what matters is family, and he cares about her and he will make her have a safe trip. What do you think she has? So what do you think about the first one? First option.
Very young.
57 is a reasonable age.
That's very young.
Okay, we'll go through the rest then. What do you think bipolar? So remember, when you want to try and diagnose something, especially in a psych setting, you need diagnostic criteria. In this setting, what are her diagnostic criteria that would make you think bipolar? So bipolar, we can use our mnemonic, dig fast. Okay, so does anybody know what D is? Distracted. What's I? Impulsive. What's G? Grandiose. What's F? Flight of ideas. What's A? increased activity. What's S? Decreased sleep. What's T? Talking. Okay, so how many criteria do you need to diagnose bipolar? Greater, is it 5? 3. Okay, so first of all, does she seem distracted? Not particularly. She seems like she's very clearly know what. Yeah, she's very focused on what she's saying. Is she impulsive? I mean, somewhat. We'd say. Is she grandiose? There's no evidence of her being grandiose. Does she have a flight of ideas?
No.
We've already concluded that you need to have a train of thought that you can't take to completion to have flight of ideas. Does she have increased activity? There's nothing to suggest that she has increased activity in that step. Is she having a decreased sleep?
No.
Okay, and maybe we can say she's talkative. So at the very least, she's presenting with 2 out of the very least 3 symptoms that you need. The other thing is you could argue it could be a hypomanic episode, but nothing still in that stem suggests that. Okay, so we can rule that out. Does she have borderline personality disorder?
No.
So she has no evidence. So what do you need for borderline personality? So what's our mnemonic? Fury's cat. What's F stand for? Help me out here because I forgot to. Okay, we'll go with N because I remember N. Unstable self-image. What's R? Relationship instability. Relationship instability. What's I? Impulsivity. What's E? Emotional, I think it's emotional dysregulation or something like that. What's S? Suicidality plus self-harm. Plus self-harm. What's Fury's? Oh yeah, C. What's C? Chronic anger. What's A? I can't remember A. What's C? P? Yes, abandonment. Abandonment. And P is like psychosis or psychotic symptoms. I can't remember what F is. Oh no, fear.
I'll pass it on.
No, this is fear of abandonment. Fear of abandonment. I'm not what A is then. Sorry? That's like black and white thinking, maybe. Is that what you're talking about? Yeah, I'm not sure. Well, in this case, what does she have? She has impulsivity, maybe. Maybe she has emotional dysregulation. But you need more than 5, by the way. Other than that, I don't know. Maybe you could argue she has psychosis. Does she have anything else? No. So it can't be BPD, and it's only a single episode, so there's no way that you could diagnose BPD, a personality disorder, based on one event. Okay? So it's not BPD. Is there any evidence of cannabis abuse?
No.
Delusional disorder. Does she have a fixed or
She can.
you could argue that she has a fixed firm belief.
But is this the best option?
I mean, she doesn't have a fixed belief that she has no ticket. She sort of accepts it.
Yeah, that's a good point actually. She accepts it. So delusional, drug induced, no evidence. Major depression with psychotic features. Again, you have to have diagnostic criteria, at least a few in the stem, to make the diagnosis. Is there any evidence of depression? No. Is she paranoid? Again, personality disorder, we can just rule all of these out. So, personality disorder. Schizoaffective, you need a time frame of, isn't it 3 months? Yeah, you need 3 months. So it's not going to be that. Schizophrenia late onset. Does she have any evidence of hallucinations, delusions, disordered thinking, disordered speech, or negative symptoms? None of those?
No.
Well, she might have one of those at least. It could be a delusion, but not confidently. So we can school that out too. And schizophrenic form? No. Okay. So that leaves Alzheimer's disorder with psychotic. I feel like a lot of you might think that I'm just leading you to the answer that I chose. But,
I trust you.
okay. I will give.
Diagnostic criteria for Alzheimer's.
I'll tell you that she does. I'll tell you why. Okay. So first of all, Alzheimer's. So psychotic symptoms, delusions, and hallucinations. Approximately 50% of individuals are affected who have Alzheimer's. 50% of them will present with psychotic symptoms. Number 1. Okay. Other times they can have misidentifications. So, for example, they might believe that one's home is not their home. They feel that a family member is someone else, etc. Delusions are typically not bizarre, as we've talked about, and hallucinations can occur in any sensory modality, but visual hallucinations are the most common. So if we were to look at cognitive impairment as is diagnosed in DSM, so what can we say? So minor. So the differences between this are what I've highlighted. Okay. So the diagnostic criteria between them are the same, except for this one says substantial. Excuse me. Sorry. This one says modest. Okay. This one says insufficient. And this one says sufficient. Otherwise, they're all the same. Okay, so if you look at this criteria, you need to have impaired level of performance in at least one of those categories. So 1, 2, 3, 4, 5, 6. So there's 6 categories, and let's have a look at if she has impaired function in any of them. Okay. The second one is that her cognitive deficits are sufficient to interfere with independence. Now, again, there's no evidence of that in the STEM. I get that, but we have this impaired cognitive mode of thinking, this impaired train of thought, which might suggest to you that she might have trouble with complex tasks such as paying bills, maybe dressing herself, etc. Again, I take we don't have the evidence for that, but there is a suggestion. Do you agree? Okay. Then the last one, it's not due to something else. And as we've discussed, there's nothing else in the STEM that suggests that diagnosis. So now let's go looking for, does she have an impairment in one of these domains? Okay. So the first 2 domains, complex attention. So instead of actually going through the whole thing, I just highlighted the examples that are in Dementia Australia is where I got this information from. Okay, so difficulty environments with multiple stimuli. No, she doesn't have that. We don't have any evidence she can recall phone numbers, so we can get rid of that. Unable to perform both familiar and complex tasks. Rely on others to plan instrumental activities of daily living or make decisions. Okay, now I would argue from that STEM where she is, first of all, she doesn't have the capacity to buy a plane ticket herself. She knows that she wants to go, but she's relying on people in her life to make those decisions for her and to be able to plan that trip for her. In which case, one might argue, especially in the way that she said it in the STEM, that she might have some executive function dysfunction. What would you say about that? Potentially. Okay, so we'll put a big question mark. And remember, you only need one. Okay? Okay, learning and memory. Repeat self in conversation, confusion about time and place. Not necessarily. Language, so she often repeats herself. She doesn't say that, and she still recognizes who her son is, so maybe not. Perceptual, so difficulties with previously familiar activities. We don't know. And then the last one is social cognition. So patients may change their behavior, insensitivity to social standards, or make decisions without regard to safety. They have little insight into these changes. So I might again argue that based on what they're presenting to us in the STEM, that she might have some impaired capacity with her social cognition. She doesn't understand what normal social conventions are, that you can't just ask someone out of the blue to plan the trip for you. So from the features in the STEM, and by ruling out the other options that were given to us, I think Alzheimer's with psychotic symptoms is the best option. But again, remember, this is always a discussion. So please put forward if you think otherwise. Anybody?
I think it's bipolar person.
Bipolar?
Yeah. You sort of get on the step, which is the irritable, sort of really comes to bipolar. Yeah.
Okay.
The grandiosity.
We'll definitely put that as another potential option then.
Sorry, where's the impulsive?
She's like when she's sort of making plans to go flying somewhere without having a passport. Or,
Yeah, it's like the whole like.
She doesn't have, there's no evidence of her having invaded. She hasn't bought it.
Yeah, but she's excited to travel there. So it's a good way.
No, but that's not what works in life.
Like that's
not what works in
that's why I chose it, because I thought it was more of a delusion. Okay, the reason I thought it was more as a delusion, because remember what our definition is: a fixed, firm belief that is out of keeping with your cultural situation, that can't be solved without, which can't be solved despite the evidence. Okay, so in this term, her fixed, firm belief is that she's going to go to Italy no matter what. Okay, because she believes that her son has the capacity to do that for her. She doesn't need to do anything. Despite her son telling her that is not something that you can do that easily. You don't have a passport, you don't have a ticket. It doesn't resolve that idea, okay? That fixed belief. Whereas impulsivity, as Roland was referring to before, would usually happen in some kind of domain. That's usually sexual, it's usually referring to money, referring to how you drive your car, those kinds of things.
But the whole like goal-oriented activity, that is like quite similar to like the kind of bipolar.
You might say it's
they
goal.
never like achieve it, they just work towards it. They're always like, oh, I'm just gonna do this.
But the thing is, even when it's a goal-directed activity, they're actively working towards it. Whereas in this STEM, all that's given to us is a belief. Okay, she's not going to the airport. She's not going on JustStart.com.
She hasn't made any
She hasn't made any plans. All she's doing is telling her son and expecting that's going to happen despite the evidence to the contrary. And that is the reason why I chose Alzheimer's as the best option. even though she is young. I do take that.
The delusion, what do you think is that she is, sorry, what?
That she's going to go to Italy. That's her delusion.
And then that, but then all the things to do with the son, it sounds like the
So
son
the,
doesn't
okay,
know
so
that she
the thing is, the fixed firm belief is that she's going to go to Italy.
Yeah.
The evidence that's provided against her is that her son tells her you don't have a passport, you don't have a ticket. So that's the evidence. That's another part of the definition of a delusion that's being presented to her.
Can't be,
So that's why I think it's a delusion.
yeah, but there's nothing else that's acceptable.
That's what I'm saying.
So it's quite a delusion.
Why the delusional disorder? What's the diagnosis criteria for delusional disorder?
It is like a month. Does that affect on personal effect on- So she's impaired as
Yeah, I'm not 100% sure. So we'll put that as another maybe. I honestly, I don't think it's bipolar, but I would take delusional disorder as a potential. But I personally don't know the diagnosis criteria for delusional disorder. So maybe look it up.
More than 1 month.
More than one of the delusions. Okay. Well, then again, like another argument is we don't have anything definitive to say she has Alzheimer's. Okay, so we've gone through that. So that was just from dementia.org, I believe, something like that. Lawrence, age 17. Now wishes he had tried harder in year 12. He doesn't get the marks he needed. Hey, he got into his course, right? He stays up late playing computer games, sleeps in,
no.
is generally more irritable than usual. Okay, just with simple questions, what do you think the answer is here? Do you think it's an adjustment disorder with depressed mood? Yeah. Okay. What is the definition of an adjustment disorder? Okay, so I should say, what are the diagnostic criteria for adjustment disorder? Anybody? Can you give me the first one? Okay, so emotional or behavioral, I'm just gonna do that, symptoms, okay, that occur in response to a stressor, okay, an identifiable stressor, so something that is definitely causing it, occurring within 3 months, okay, within 3 months of the onset of the stressor, Okay, and in this case, you might say there's no time frame given to us in the question. I'll definitely argue otherwise. He's only 17 years old, okay? So he couldn't have finished year 12 that long ago if he's still 17. So he probably is still within 3 months. So we definitely have that time frame in this question. There's an identifiable stressor that he hasn't finished year 12, and he has emotional and behavioral symptoms. What do we mean by emotional and behavioral symptoms? Usually something that significantly affects your social functioning. So he's only staying at home, he's sleeping all day. So it definitely is having an impairment, okay?
Can you say that's also pretty normal behavior for a 17-year-old after you graduated year 12?
That's what I thought as well.
Well, not necessarily, because he's more irritable than usual as well, okay?
I was pretty irritable when I was playing games.
And the thing is that it always says most appropriate and normal behavior
Probably
isn't in there.
lost a couple of weekends.
Maybe. Okay. And the other thing you need to know is that the symptoms will resolve within 6 months, okay? That's adjustment disorder. Okay. 6 months onset of the stressor. Okay. Colin, he's 72, struggling to deal with the death of his wife 2 years ago. It's a normal grief reaction. That's correct.
What number was that?
Okay, 58. Just normal grief reaction. Just because we've got so much to go through, I'll go through the clear-cut questions quickly. Okay, so in a consultation with her GP, 7-year-old boy, okay, he is concerned that someone's having nightmares of being kidnapped, was reluctant to go to school, frequent reassurance when his mother was in close proximity, that he had complained of nausea and headaches. Now just keep in mind, somebody who's 7 years old will probably be in year 2 or year 1, one of those years. So they're pretty old, okay? So what do you think he has? Separation anxiety, okay? So how do we define separation anxiety? Nobody? Okay, so separation anxiety, very clearly defined as distress in being separated or anticipating separation from a parent or a caregiver that is excessive for the child's age. So it might be normal for somebody who's 2, 3, 4 years old, but he's 7, so it's not normal for his age. And that prevents him from participating in age-appropriate activities. In this case, that would probably be school, and he doesn't want to go to school. So separation anxiety, clear cut. No. And the symptoms have to be present for more than 4 weeks as well. Now, the other thing in this stem that we need to have a look at is reactive attachment disorder. Does anybody know what that is?
Isn't that just angry?
You have to tell me more.
It's like, they deal poorly with people, and when.
Tell me about how they grow
like,
up.
Closeness, kind of like poor parenting, like distanced, maybe slightly.
Okay.
abusive.
Distanced. Yeah.
And
Abusive.
the result is just like a child that doesn't really respond properly to like social cues. So if people are upset, they don't really care. Kind of a bit aggressive. They don't really listen to instructions, and they sort of share like
Okay.
love from other people.
So that's reasonable. So the way it's defined is it's a disturbed, disturbed and developmentally. So this is the important word. Developmentally inappropriate response relating to most social situations. Okay. So for example, if somebody comes to say hello to you and they're very nice, have a big smile on your face, then you're just completely blank faced. So that wouldn't be normal. Or your mom comes to give you a hug and you don't want to hug her back. So it has to be developmentally inappropriate and it has to be significant. And the other thing is that it has to be a persistent failure. Okay. So it can't just happen a few times. It can't just be because the child is shy. It has to be a persistent failure. Okay. To initiate or to respond to most social interactions. Okay. And it usually arises from a failure to form those normal attachments that you would get from your primary caregivers in early childhood, which is why the normal timeline for these kind of people will be ones who come from an abusive household, one whose parents are very distant, they go through constant foster care, so they're not able to form those normal social connections. So that's reactive attachment disorder. Okay, next question. So Jed, he's 8 years old. Her mom is very concerned about his behavior, won't follow rules, no regard for the feelings of others. What does he have? What was it? Conduct disorder. Good. So if we look at other similar conditions that affect people in their childhood, we have 3. Okay, so the most similar are these 2, oppositional defiant and conduct disorder. The difference between them is somebody who has oppositional defiant disorder is not aggressive towards people and or animals, or they don't have a disregard for other people's rights. Okay, so somebody with oppositional defiant disorder is just maybe one of those kids that you see on TV. You know how they used to have those nanny shows on TV? Super Nanny, what was it called? And she like tries to make those shows, and she tries to correct the children, correct their behavior. So those kind of kids would have oppositional defiant disorder. People who have a pattern of angry and irritable mood, argumentative, defiant, and vindictiveness for more than 6 months. So what do we mean by this? Short temper, touchy, easily annoyed, argues a lot, refuses authority figures, so in this case, usually parents, teachers, blames others for their actions even when they make a mistake, and they're very spiteful. So that sounds like your normal toddler, but just more severe in this case. Compare that to conduct disorder. So a bit different in that this is a repetitive and persistent pattern of behavior in which the basic rights of others are violated. Okay? It's a precursor in a lot of cases to antisocial personality disorder. But for a personality disorder to be diagnosed, you need to be more than 18 years old. And the last one is an intermittent explosive disorder. Okay, so just sudden outbursts of anger and violence, completely out of nowhere, to the point of rage. Okay, so you need to have more than 2 a week for more than 3 months, or you need to be damaging property. Okay, and often what they will say once they've had these outbursts is that they either feel remorseful, or they feel relief, or they feel pleasure. One of those 3. Okay, next question. So we have Faye. She's 57, angry at her present situation. She's she's had multiple court cases over many years, seeking compensation from people and organizations that have treated her unfairly, and she has alienated her family and friends who have been sued, while the advice and support of others have not been appreciated. What do you think she has? So we have a long-term history of not being able to trust others. What would that be? Paranoid personality disorder. Okay, next question. So Greg, he has a successive career. He drinks a lot. He experiences mood swings, often precipitated by arguments with his girlfriends. no girlfriends. Okay, S. He cuts himself a lot, and that relieves his feelings of emptiness. This is a clear-cut borderline personality disorder. If
Clear cut.
girlfriends, he has more than one, I think. So he has a fear of abandonment because he was running away. He has multiple unstable relationships because he argues with lots of people. I think he said he was driving or something. No, he's drinking. So he was drinking impulsively. He's very unstable because he was crying. He was self-harming himself. He said in the question that he felt empty. He has anger problems. And I thought this was interesting. How Anakin killed a whole group of sand people. And he has
What?
paranoid.
What?
Some people say that Anakin Skywalker might have had borderline personality disorder. And he didn't necessarily have paranoid ideation, but he fulfills more than 5. So he has borderline. Next question. So John, 62, has lived at various rooming houses since his parents were killed in a car crash 15 years ago. He is very dependent on others. He can be loud and forceful at times when somebody else took his turn. Reacting in that way, is that normal for a 62-year-old? No. The rooming house manager, so he lives in a house, in this kind of house, finds his room easily. He knows what activities are on for that day, which means that he has repetitive tasks or set schedules, repetitive tasks. He doesn't have any psychotic symptoms by saying you're being silly, which is quite premature language. He's not allowed to handle money. What do you think he has? Intellectual disability. He doesn't have any psychotic symptoms. I like that person's agreeing with you. Okay, so Mark, he's 21, not doing as well at university since he started using the devil's lettuce, which he does most weekends. Unable to stop once he starts. Okay, these are all really important. Please keep all of these things that I'm going to underline right now in mind. Okay, unable to stop once he starts. Okay, close enough. Can't study effectively. Doesn't seem to experience any withdrawal symptoms. Okay, let's go on to the next page. So substance abuse disorder, how to diagnose it. I've paraphrased it for you here because it was very long. I thought I'd try to make it as simple as possible. So there's a mnemonic that you can use, kids. So overuse, craving, impairment, dangerous, and systematic symptoms. So he has overuse, he's using it every weekend. So if we just wanted to simply go through it, he has craving if he's using it that often. We can't say that definitively, but he definitely has impairment. So at the very least, he's fulfilling through those categories. If we were to look at it in depth, using more than intended, or we don't know. Unsuccessful efforts to cut down, yes. He doesn't have craving, no. Failure to fulfill responsibilities, okay? So he's unable to study for his exams because of that. Giving up activities, in this case, doing his homework, okay?
That's a good question. Is it 2 or more or greater than 2?
Oh, I never do more or equal to. It's usually 2 plus, so including 2. You need to have at least 2.
Okay.
Yeah. So he has cannabis abuse. Agree? Okay. So cannabis abuse differs from cannabis intoxication. What kind of symptoms would you expect with intoxication? Scleral injection is one. Dry mouth is another.
Hunger.
Increased appetite is another. And there's the last one.
Paranoia.
Tachycardia. Okay. So these are your 4 cardinal symptoms of somebody who's had cannabis intoxication. Okay. So Julie is 17, so she's quite young. She is behaving very strangely after her final exams. What do you think she has?
Drug induced.
Drug induced. What drug did she use?
Ice.
Okay.
Ice. Speed. Whichever one you want. Same thing.
She's 17 years old. What drug do you think is most likely that she used?
I know you should read.
Anybody?
Read.
Okay, epidemiologically, what is the most likely drug that she has used to result in a psychosis? No.
Heroin.
No.
Alcohol.
Yes. Okay, alcohol. So never forget that alcohol is a drug. This is what society has done to us. We no longer consider it to be a drug, but this is not definitively, but much more likely to be an alcohol-induced psychosis, okay? It's much more common than you might think, okay? There's an 8 times actually, I don't know what that's in reference to, but it significantly increases your risk of having a psychotic disorder. People who are reliant on alcohol, okay? Cannabis can trigger psychosis as well, but always remember alcohol is much more likely. Okay, next question we have Maria, she's 68, presents to the ED, and she is confused in the context of recently commencing treatment for an episode of depression, does not have a tablet with her, and her family's not sure what she's taking. What do you think she needs? What does she have? No. Yes, okay. So she probably has hyponatremia, okay? Why does serotonin cause hyponatremia? Does anybody know? So the pathophysiology is not completely known. The theories that exist say that it's likely due to SIADH, so syndrome of inappropriate ADH secretion. So serotonin, by whatever mechanism, I didn't go that far into it, causes more ADH to be released in your body, okay? Which then causes you to retain fluid, which decreases the osmolality in your ECF and therefore causes you to have hyponatremia. The symptoms of hyponatremia are very non-specific, which is why she's presenting with tiredness and the such. Okay, so again, thank you to Cecilia Zhu, who gave us all of these amazing, or most of these amazing mnemonics. So this is another one to remember the adverse effects of SSRIs. So bleeding in reference to what most commonly? GIT. So if you guys remember back to when we were doing some bio questions, we talked about carcinoid syndrome. So carcinoid syndrome, what is the symptom that's associated with that? Secretory diarrhea. And what is the diarrhea secondary to? What is carcinoid? What type of tumor is carcinoid? It's a neuroendocrine. And what is the release? Serotonin, because the serotonin receptors within the bowel. So very similarly, an SSRI causes bowel discomfort, bowel dysfunction, not necessarily the bleeding, but the diarrhea and the upset that you get because of the serotonin receptors that are present within your bowel. Okay? It causes weight gain, I don't know how. Orthostatic hypertension is a very common. Sexual dysfunction, worse with particular medications. For example, paroxetine is probably the worst. Sedation, insomnia, GI upset, especially very common in a lot of people. Hyponatremia due to the SIADH, serotonin syndrome, usually if you use it with other medications. So common ones would be a triptan. Other ones I haven't got here would be tramadol, St. John's wort. Anything really that can decrease the metabolism within the liver. Okay, so anything that blocks your cytochrome P450 enzymes and sweating. Okay, so another important thing is you must avoid an NSAID when you're on SSRIs because of that risk of bleeding. Warfarin, I'm not sure why you have to avoid it, but you do. And
Bleeding.
sorry? All right, bleeding. True. And I haven't got everything here, but you need to, just a heads up, please make sure that you're able to counsel a patient if you are in a depression station and they're starting medication. Okay? You need to be able to tell them how long you need to take medication for, when you can't stop, what kind of side effects there are, what the benefits are, etc., etc. Okay? Please. Okay. So next question. So we have a 72-year-old female. She's in high-level care, and she has restiveness and physical aggression in the context of an observed fall 24 hours ago, and she didn't lose consciousness or hit her head. What do you think she has? Why has her behavior suddenly changed? Okay, so it says here, in the context of personal care. So this means when the carers come into the room, they try to dress her, they try to put her on the pan, they try to wash her. So when she's being mobilized and when people are, actively moving her and touching her, that's when she's becoming aggressive. Why do you think that's happening? What has she had? What do old people get? What? Okay, I'll put differentials down here. UTI. What other differential do you think she might have had? Delirium. Okay, what else?
Stroke. I don't think we actually had. We asked what the old.
Okay, what else? In the in context of the question.
Elder abuse.
Yes, okay. So what fracture are we investigating specifically? A NOF, okay? So she's most likely had a NOF, okay? Right, a NOF, a neck or femur fracture. So she's fallen over, and that is why we're always so concerned about the elderly falling over, because they're very brittle. When they fall over, they break their bones. The most common bone they break is their neck or femur.
I just thought UTI.
That's the most important part, okay? So she's becoming aggressive because it tells you in the question why she's becoming aggressive, okay? Because she's got moderate cognitive impairment. And as we went through that list, it might be difficult for her to verbalize to the staff why she's becoming aggressive. So when you move her, she's getting excruciating pain. And the only way that she's able to display that she's becoming aggressive and trying to push them off her. Does that make sense? So she's definitely had enough. Well, not definitely. 98% likely that she's had enough. Okay, so she needs an X-ray.
I thought she felt conscious she had UTI.
Okay, next question. We have Michelle, who's 18 years old. Please keep that in mind. She has euphoric mood, reduced need for sleep, and increased goal-directed activity.
Lithium level.
Who said urine drug screen? Okay. I'm a bit disappointed, to be honest. Okay, why do you guys think it's a urine drug screen? Okay, so for this type of question especially, when we have a set of non-specific symptoms that are being presented to us, first of all, then we always need to use our diagnostic framework, or we go from most common to least common, least likely, okay? So first of all, what are differentials for somebody having euphoria? Anybody? So differential for somebody having euphoria. Mania? What else? Anybody? Drugs. So drug induced. What else? Increased thyroid. What else? Anything else? Absolutely. So Graves' disease. So something like Graves' disease, which is a cause of hyperthyroidism, has a very high prevalence of neuropsychological symptoms, of which include mania, anxiety, depression, psychosis, although that's less likely, but it's very common. And that is why when you're taking a psych history, you always ask about organic symptoms first. Now, remember we've talked about the utility of a urine drug screen. We've talked about it, remember? First, okay,
Remind us.
I'll remind you. So first of all, a urine drug screen can detect many drugs. Second of all, it'll take a few days to come back, by which time many of the medications might have cleared. Because it doesn't come back instantly. It's not something you just dip into the urine. You need to send it off to the lab, and it'll take a few, usually 24 to 72 hours for you to get that result back, okay? The second thing is that, what's the point of doing a urine drug screen if she's coming into your clinic and telling you her symptoms? If she was that concerned, she would have told you that she was on drugs in the first place. So what diagnostic utility does it actually have? So the first investigation, and one of the most important, is thyroid function tests. Because hyperthyroidism is a very common cause of having euphoria, okay? Does that make sense?
1 week history in someone aged 18.
Absolutely.
I thought it was just like relapse of bipolar, and you should check if she's any.
Okay, first of all, you can't assume that she has bipolar because there's no suggestion in the question. And the second thing is that, but the second thing is that even doing a lithium level, okay, is not necessarily going to be useful. Okay, the reason for that is lithium level can show you if they have toxicity or not, but people can become symptomatic. That's why they're called symptoms of medication, adverse effects at any concentration of the drug. So that itself is not going to be useful in the first place. So that is why I'm very, very certain that the answer here is thyroid function test. You can look. The thing is, first of all, you wouldn't be able to do that in a GP setting.
I'm pretty sure you can.
I-
No, there's a cup thing. I'm not sure you still refer it as urine drug screen, but there's the cup that
You might be able to do drug reagents.
Oh, it's not like really sure what that is. I think if you want like exact.
Yeah, I'm pretty sure it's not
Okay.
exact, but that's.
I want you guys to take a step back and put yourself in the GP seat. Okay, right? Pretend I am this 18-year-old girl, and I come into the GP setting and I tell you, Doc, for the last week, I've been having this really elevated mood. I feel really good all the time. I mean, I know it's a good thing, but it feels really odd for me. It's not really that normal.
What drugs have you been taking?
I can't sleep normally. I can't sleep normally, and I feel like I'm just going on this one track all of the time. And then the next thing you're going to do is refer me for urine drug screen.
Yeah. For instance, yeah.
Okay.
Okay, I
So-
see what you
You
mean.
can just do organic screen for all organic stuff.
which is the thyroid test.
But you also
Fair.
still want to do a urine drug screen, wouldn't you?
No. Urine drug screen is not an organic test. You're testing for substances which itself is neither sensitive nor specific. It might, first of all, has a high false positive rate. Second thing is going to take time for you to come back. In which case, what are you going to do? You're going to tell her, don't take the drug. The point I'm trying to get to you is what management value does it actually give you?
Fair.
First of all, it's going to take days to come back. Second of all, even if it comes back positive, what are you going to do? You're going to tell her, don't take the drug. She isn't coming in with toxicity, so it's not like you can give her an agent that's going to reverse the effect of the drug. Okay? Third thing is, what drugs cause you to have euphoria?
Heroin,
Amphetamines,
opioids.
cannabis as well. Opioids can. In which case, she would be coming in with other symptoms. If she was to that degree, because a high does not last that long, then a urine drug screen might be reasonable if she's coming in unconscious to the ED and you do not know what the cause is. But even in that case, you'll probably do a clinical trial of naltrexone anyway. So what I'm trying to say to you is that urine drug screen, I can't think of a situation other than what I've just told you, where the patient is unconscious, you don't know what the diagnosis is, and you use it as a screening investigation, has no clinical utility whatsoever. If you miss a thyroid condition, especially something hypothyroidism, that is significant. Hypothyroidism is something that can cause many different symptoms in your body. The first thing that you're going to look for is not for drugs. You want to look for an organic cause, which is why when somebody's being initially diagnosed with something like Alzheimer's or dementia, what is something that you have to do? An organic screen, okay? You don't do a drug screen because they're coming with impaired cognitive function. You do an organic screen. Very similarly for these situations. And why always in a psychiatric history, in your psych OSCE stations, you always ask about organic symptoms, which includes thyroid symptoms. Have I pushed that point across enough?
Yeah,
Okay.
That's accepted.
Let's start asking.
I'm sorry. I feel very strongly about urine drug screens. Even though I have no clinical experience whatsoever, I don't like it.
I'm just sick of screening
Do you
everyone
just
that
not
comes
want to
into
get
Psych
like
today.
yourself or something?
Yes.
Can I
So-
have whatever you're having.
Marvin, 23, has a 2-week history of agitated and odd behavior. His family delayed bringing him to the ED because he was uncooperative and the problem seemed to come and go. This morning they found him lying on the floor and difficult to rouse. He appeared to have been incontinent of urine. What do you think he's had? So he's not drugs. Okay. We're just gonna do that, okay?
It's a
Okay.
seizure, right?
It's a seizure, okay? Not necessarily a seizure, but he's having what is most likely epileptiform or seizure syndrome, some kind of seizure syndrome with impaired consciousness that is not secondary to drugs.
You can't necessarily say.
I have a question. If it's not secondary to drugs, what is the odd behavior?
Probably a
Underlying-
post-syncopal episode.
Post-syncopal, confused.
Yeah.
Yeah. So especially when they say difficult to rouse, there's probably post-syncopal confusion as well. Okay.
Yeah. No, I
These.
meant like the 2-week history of the weird behavior, like in the first line. How it says just like odd behavior, odd agitated behavior.
I'm not sure. Yeah. But in that case, what's the best investigation? So MRI, I would also agree with. I'd also agree that's a reasonable answer. But just because of the next question, I want you to choose another one.
Is the biggest mimic.
Okay, so the reason I think MRI brain is also a very reasonable sort is because you want to look for functional changes in the brain.
Yeah.
Okay, but before that, you probably do a CT brain anyway. Okay, which makes MRI brain less likely. So what's the other thing you do to look for seizure activity? An EEG. And EEG is also not difficult to refer to.
Yeah.
Right.
Wait,
To do a referral for.
If he's gone to hospital already post seizure,
You probably have a CT brain. Yes,
yeah. So
but he's not in.
do you know what I mean? Like he's already had this.
Is this the most appropriate investigation?
So it's actually option to start with option for getting
It doesn't really give you much information.
Yeah, but like especially if he's like post seizure, like it's gone and it's over, and then you take him to hospital. And then
I suppose the answer
Because
really
it-
depends on whether by most appropriate, I mean like the most appropriate initial set of things you should do or the most.
And plus the frequency is quite high, so you can probably capture it while
Yeah,
I mean, yes,
Because
yeah, like in
EEG
24 hours.
will allow you to identify what type of seizure activity it is, and will allow you to target therapy as well. I'm not saying that imaging is not important because you want to look for any structural abnormalities in the brain.
That's done at one point for this person.
Yeah, but maybe it's not the. I know it's hard. I'm not 100% sure, but
Let's
EEG
do the next
seems
question.
reasonable.
So we can say,
You would have had a CT, but the sentence says assume that no other investigation has been ordered unless specified in the opinion.
I'm saying in real life you would,
Oh, okay.
and I'm saying that patient should as well, because you want to rule out any structural abnormalities. Okay, so we have Terry. He's 63. He has a 5-month history of cognitive decline, gradual onset, and of progressive course in the absence of any significant past medical history. An MRI brain. Okay.
what's going on there?
I just came out of
Okay, so can you guys please excuse me for just 5 or 7 minutes? I just need to pray quickly. I'll be back soon.
How dare you talk?
Oh,
I think it's every quarter.
oh no.
Please get back.
Hey, everything's being recorded, right?
Everything we said.
Okay,
It's on the recording.
do you guys want me to put an Oscar up on there?
Okay, it's on the holiday, you know.
We're not public.
Hey, is he gone? Testing. Testing. Huh?
My league on his service. The $1,000 league machine. Jesus Christ, this is like chain of incorrect answers over and over again.
Yeah, but if you keep picking your
Where do you
judge
actually get
screen,
exam papers?
You get none of the right. You feel good about it.
What the hell's that?
You Google Monash Queller, that's where Monash put all the exams on.
Oh, I didn't know.
Hey, it's back, you can't do this.
I came back to see what you're talking about.
Oh.
we're involved.
What's this? Ah, thank you. Well, what is it?
Oh, wait, I hate that. No, Joy, don't do it. Don't traumatize more people.
Domjin,
Yes?
prefer a Steam card or do you prefer straight cash?
Dipples is the
Cash.
word.
So I was thinking, I looked at,
Forget it, cash.
yeah, because Steam cards suck dick here. Because
Plate
basically you get
tea.
conversion from $20, it goes down to $40.
Yeah,
Tea.
exactly.
I don't know if I,
Waste of
USD,
money.
so it's
I
so
don't know
bad.
if I can.
Yes.
Why does
Money.
our economy suck? What does our country suck?
Yes, money.
It's fun. I've seen more
What's
women.
fabbing being like fabulous?
I
The act of being fabulous right now. Here and there.
I wasn't allowed to see it. Every time they come in, it's like, no, you're supposed to say hi to your face.
Oh,
Oh, and then.
maybe it could end.
Yesterday, no, not yesterday, Tuesday, this
Bang.
Tuesday, I had to
Bang.
go to test me, but I haven't done it for 4 weeks. And she feels like, I think test me have you done? I'm like, oh yeah, too many. And he's like, oh, okay, you can do this one. And then I'm like, all right. And then I'm like, how did I do it? And then like, okay, so bring your heels to your bottom and spread open your leg. Like,
I don't think so. I think it's gonna.
whatever, we'll move on. And then I get the
Everything's on going on YouTube.
whatever.
Yeah.
You're gonna be famous.
And I got the test done, and now I need to take the speculum out, right?
Oh.
And now I just took it out.
Oh my god.
And the lady was like, ow! I'm like,
Oh my god.
oops. Sorry. Adventures in GT, man.
Does the imposter tears to Donnie?
Oh my god. It was good for it was good for my learning, not so good for the patient.
I got like a postpartum 6-week check for both the mother and the child. And I got like an antepartum station. Patient come in.
Yeah.
It was like, oh you have to answer, oh yeah, vaccinations, OGDT results, ultrasound results, and then like antenatal clinic. It's so
No. Ah,
so much antenatal.
it's so cool. No, look at no, not.
All my,
I have no abdominal
there's
muscles.
like
That's
nothing
how
up
you
until
learn.
60s, and then it's like
If you poke
keeps going
it,
up.
it's all soft.
My highest category is in the 90s.
And you
through-
also just did that over YouTube.
What? Whereabouts are you doing it?
Let me guess, it's a male white thing.
Yes.
Oh, what a
Look,
coincidence.
this is-
Mine is like
Male,
mine's basically opposite guy.
Where is it?
80% female.
Mine's Pete and Oxygyn. I have a female.
I don't think you're going to be doing that.
Um,
No, not for the first few years, but for the next few years. I mean, like,
I had I went
It's
to
so
the consulting
cool.
and then
Let's
I
go.
had this
Alright.
guy come
No, I
in,
don't want to do it.
sent him
I'd
like
rather
his
do
picture
something
Half the consultation
else.
is neurotic.
because the
Nice.
naturopath looked at his face
It's not
and
pulled
saw
up.
the rest, some rashes that were
Like-
not mental.
I
And
don't
she was
know.
concerned like, oh, I'm concerned this is mental. You should see the
Sounds
doctor
like
like tomorrow. or the
roast
day after or
potato.
something. I'm just sitting there like, she was thinking mental solution. She saw the rash. She should have like said just eating. Like,
That is so true.
at that
Why
moment, first of all. And the second of all,
It is, but just trying too hard for a good
guy,
word.
pure muscle.
You're already
pure massive
like
muscle.
90 points ahead.
Like his
80
his
points
blood
ahead,
pressure is
15
like
off.
one.
Who is this young person? I feel bad for.
Yeah, exactly. He's like, dude, walking there, how's it going, man? And his hands shake.
I will play something else for her.
Like, what can I do for you? Oh, yeah, I got this rash, mate. And he's like,
How do you?
what is it? The
Why is
natural
your
part is
computer
it's
so
like
stupid?
meningococcal or something. So I just came to like get
Make
checked
use
out.
of the
Like,
word. Like,
you meningococcal rash?
stroke this. Stroke this. Wait.
Yeah, and then I looked at it. It is not really rash, but like, yeah, his platelets, recent. Yeah, we did the script. It's like he had a recent viral kind of content with like neighbors have
Is that-
similar symptoms. I'm like, probably not. And then I showed it to GP and she was like, oh, what's that? Ah, okay, that's exciting. Actually, you too. What's this? Rules for using a mental health. So bad.
Okay.
Oh,
Jerry.
Why is this only this much? We need another one for the second half. Why do you come unprepared?
It's not my fault.
She does like psych as well, so I saw her like.
Waddle. Woman suffers damaged intestines after eating extra spicy ramen for a week.
Oh my god.
Yeah, she goes viral.
It's okay. You just do like really random kids one.
It brings your GP one up.
Everyone.
I mean, it brings your wins
Everyone
one.
does go to the people. The average is 96%.
Yeah, but
average.
Everyone looks
ask
good.
the patient,
50%
right?
of
So it
people
brings
get
your
up
wins
get
one up.
90%.
I
This is like 60%.
know, that's why you do Olympics, to lift up your winners.
Yeah, no, but if you can't do well in kids, that's what I'm arguing. You literally can't do
No,
well.
it's the average. It's the average.
Ketoscopy is the hardest one to do, right?
Yeah.
Why is ketoscopy?
Oh, that's hard. Wait, I'm missing Petos. Wait, did you say Petos is hard?
I thought you said no.
Almost. I disagree. I don't think.
I think
don't think-
GP is the hardest. Somebody told me that. I haven't done it.
I personally think women's.
Because I just have a look.
I think
And
GP
GP
is like
With
women's
the 9
is
o'clock one.
women's is like only a certain amount of things they can.
Oh, wait, are you coming with
Women's
us?
is like memorize God.
Because you want in the group chat, because I don't,
That's
you don't really
so
come to
annoying.
this.
Oh, the nun thing. Yeah, Joy asked me
Like, in
Thanks, sir.
Or tocolytic.
Let's just like right up on the
Wait, you have to know which tocolytic to use? Why can't I just say, I'll use a
1, 2,
tocolytic?
3,
Therapy.
Probably just you really want to
5.
One that you're gonna
You
use
get
for
it for
most
10
things,
right?
one that you're
I
gonna
can
use
get it
for
for
the
Because it's-
ECB.
Yeah, what's the name of the one you
You
drop?
use the Cetapin.
Amphetamine.
It works as a
Amphetamine.
it has.
Amphetamine is first line for like psycholytics,
Like
first line
amphetamine
for
as in like
I'm gonna.
the
Calcium
drop.
plants, not
Yes.
plants, yeah.
The
High
Cetapin.
blood pressure.
Oh, the amphetamine.
Yeah.
High blood pressure amphetamine.
Not that.
Apparently the
Patient like
It's propanol, isn't it?
92 years old. This
For what?
like granny pretty well
Yeah.
actually himself.
For what?
And then he went to,
I
like,
think they're
Alfred,
beta blockers for
and
Benadryl,
they
but
got prescribed.
for what? Amphetamine
Don't you?
becoming more used
Yeah.
than Benadryl.
So there are 4 drugs you can use. The most common is probably betalol.
But like apparently the
Amphetamine,
Benadryl.
hydrolazine, and nicotine.
Yeah.
Methadone
Apparently
probably for hydrol.
Benadryl
Hydrol is
becoming
another
more
one.
used.
So it's not.
I can't remember where I heard this from. I could have just
I have
Googled it.
yes, it's okay.
I could have just dreamt it. I think my GP might have said it, but my GP's not that reliable.
What are you finish on?
Kind of love migraines.
What are you on right now? What are you on right now?
Great. And then they use themselves.
I get more women's opinions on GP than GP.
Yeah. I've like changed so many GPs now.
All I got for GP
One's
is
like left for practice. The other one was like away for 2 weeks.
I looked in the ear the other day, and the GP's like, "Oh, what does it look like?" I'm like, "It looks normal to me." She's like, "It looks like it's about to burst."
I can't see the ears. Like, I look at it. Yeah, I see what you're talking about.
To be fair, the very first ears I saw, I looked inside the left ear, and I was like, "Wow, you put it straight in. You see the eardrum, light reflex, everything perfectly." I was like, "Wow, this is the first eardrum I've seen in my life. It's amazing." Spot clean. And then she's like, "I'll take a look at the other ear." I take a look at the other ear. I was like, "Wow, screwed otitis media." It's like it's all white and it's like a perfect eardrum, like perfect piece of when I put it there. I'm like, wow, I didn't expect to see that with my second ear that I saw.
Yeah, like no.
I did look in the normal ear first.
Yeah, I just can't see anything. Like everything's blurry. I just give up. I just assume in the Oscars they're not going to give me a. It's just in real life. I'm just going to have to consult second
How's it been
opinion.
going, Cody? How's it been going, Cody?
Hi, Jasmine.
Hi, Taha.
Hi, everyone.
Movie that's like 50% rating.
Let's get cracking.
Okay.
How many times do you see us back?
What about Taha? What
How many
about
slides have you got? You're doing well. Not really.
what
Let's get cracking.
Taha?
Okay, everyone.
76.
I really don't want to watch them.
So everyone, thank you very much again for your patience. I always appreciate it very much. Apologize for swearing before I didn't know what happened. Okay. So for the next question, I just thought I thought it'd be a good idea that we go quickly through Mental Health Act and mental health law, because I believe it will help us to answer the questions more easily. Okay, so first thing you need to know about involuntary treatment of a patient is to know what the criteria and rules the patient needs to fulfill before they can be involuntarily treated. Okay, so I've very much synthesized this into 3 main boxes. First of all, the patient has a treatable mental illness. So that specifically means that they have a mental illness that you know you can treat by taking them into hospital, giving them medication and staff support, etc. Okay, and this patient right now needs immediate treatment. Okay, and you are able to provide them with that immediate treatment, which means that they don't have to wait in the cell, for example, but you can give them treatment as soon as they arrive. And they need that treatment because they're going to harm either themselves or someone else, or are at risk of deterioration. So for example, you can see the warning signs of them deteriorating in the schizophrenia, for example, if you don't treat them right now. That's the second point. And the third point is that there is no less restrictive way that you can treat them. So that would mean you can't treat them at home without putting them under an act. They must come in. Okay, so it also applies to people who are children. And this is really, really important. It does not imply that the patient cannot give consent. A consenting adult can still be treated under the Mental Health Act. Okay, so just basics that you need to understand about the MHA. Okay, so this is a step-by-step guide of how to use the Mental Health Act to treat a patient involuntarily. Okay.
Just with that, if they're consenting, why do you treat them under mental health act?
So by consenting, what I mean is they're able to give informed consent, so that they have no impairment to their ability to give informed consent, but for some reason or otherwise, they still need to come into hospital. I wouldn't be able to give you an example off the top of my head. Okay, so step-by-step guide. First step to initiating the Mental Health Act is to make an assessment order. Okay, so that purpose is to enable an authorized psychiatrist to examine that patient without the patient's consent. Okay, but they can be consenting, as we talked about, to determine whether or not they actually have a mental health illness and whether they need to be taken into a mental health service where they can be managed. Okay, so who can order an AO? Any registered health practitioner. So that can be a social worker, it can be an occupational therapist, it can be a nurse, it can be a doctor. So there's a lot of people who can do an assessment order. Okay, and with everything that I'm going to talk about in the next few minutes, what I need you guys to remember is that you always want to treat them in the community before thinking about treating them as an inpatient. So wherever possible, keep them in the community unless for whatever reason they must come into hospital. So that applies for pretty much everything in the Mental Health Act. Okay, so step one, I've made an assessment order. So say I'm the nurse and I think this patient is really sick, I make the assessment order. So ASAP, with P actually being practical in this case, so as soon as practical, the authorized psychiatrist must come to see that patient. So when we talk about maximal time that somebody can be under an assessment order, this is what this timeline is referring to. Okay, so 72 hours is allocated to the patient to travel to the designated mental health service. For example, let's say we have a patient who's coming to Wonthaggi Hospital, which has no mental health services. So from the time of the assessment order being ordered, I have no better word, they have 72 hours to get to MMC to be able to see the psychiatrist, okay? When they arrive at the hospital, the psychiatrist has 24 hours in which to see the patient, okay? As soon as practical. Now, just before that time finishes, they are allowed to extend that up to 2 times. So they can extend it for 24 hours, and before that finishes, they can extend it again. So that is a total of 72 hours, plus potentially 72 hours of travel, which would mean that you're under a Mental Health Act for
6 days.
6 days, which means you're under a Mental Health Act for 6 days. 144 hours, okay? So 6 days in total, maximum. So that's the theoretical maximum that you're under an assessment order for. Okay, so then at the end of that, the psychiatrist can either make 2 decisions. So one would be revoke the assessment order and say this patient is normal. They do not need to go under a treatment order, or they do make a treatment order. And otherwise, if you can't meet the deadline, the AO is automatically revoked. So then the next one is the TTO. So once the assessment order is seized, you order a TTO, which is a temporary treatment order. So what is a temporary treatment order? We'll go into this page. So a temporary treatment order allows you to give compulsory treatment. So under an assessment order, you cannot give them compulsory treatment unless you urgently need it. So for whatever reason, let's say the patient is acutely trying to kill themselves, then you could treat them under an assessment order, but otherwise you can't treat them until the authorized psychiatrist has seen them and made their decision. So the TTO allows compulsory therapy. Now, with any of this, you always take the views of the patient, the carers, the parents, anybody who has a stake in that patient's healthcare. You always take their views into concern. All right. Okay, and the person, now, I'm going to read out a paragraph that is directly from the health.vic website, because I wasn't sure if my interpretation is correct or not, but it says, an authorized psychiatrist who made a person subject to an assessment order cannot conduct an assessment of the person and make the person subject to a temporary treatment order. So what I gathered from that is, if you were the one to order the assessment order and you're a psychiatrist, you are not then allowed to order a TTO for the same patient, is what I interpreted from that paragraph. But I am not sure if it also means I am the authorized psychiatrist and I examined that patient. No, that doesn't make sense. I think it's the other one. So if I made the assessment order, I am not allowed to make the treatment order. Okay?
I think it's basically just a safeguard so you don't immediately put them on a.
Yeah, I imagine so. So just keep that one in mind. So the same psychiatrist can't do it.
So you need to, okay, so yeah.
No, you don't. You can only be, the thing is that, remember, anybody can make an assessment order. But if it was a psychiatrist who made the assessment order, they're not allowed to make the treatment order.
Okay. Will they even need to make a assessment order? Can they just go straight to
No, you need an assessment order, because the assessment order, but that's the point. The assessment order gives the order for them to examine the patient and make a decision if that patient needs to be involuntarily treated or not. Okay, so you can't instantly go to a TTO. Okay, so then a treatment or a TTO, I'm just going to call it TTO, it's easier, lasts for 28 days unless it is revoked or expires earlier. Okay, so, and I think I read somewhere, but I couldn't find it again. I think you can extend it up to 42 days, but I couldn't find the source that says that. So for the moment, just assume that it's 28 days. Okay, now, so 10 days before the treatment order, the TTO, is set to expire, the Mental Health Tribunal must make a decision about what to do. So that's why I put 18 days, because 18 days is the theoretical maximum that they have to make the decision. So they will decide either to revoke the TTO or to put the patient under a treatment order. Okay, so now we've done step 1, we've done step 2. And let's say the MHT, the Mental Health Tribunal, have made the decision. Now, previously in the past, I think before 2013, the Mental Health Tribunal would only be like the second opinion. They'd only confirm your decision. But with the new Mental Health Act, they must make the decision based on your recommendation. Do you understand the difference I'm trying to? Yeah, good. Okay. So then a treatment order. A treatment order. So there's 3 types. There's a community treatment order. There's an inpatient treatment order, and there's one for children. Okay. So for any child, no matter what they have, is 3 months, even if it's an inpatient or community treatment order. For an inpatient, 6 months. For community, it's 12 months. Okay. Now, if at any point you decide that you need to change the patient from community to inpatient, then you need to inform the Mental Health Tribunal within 28 days. And I think they might need to make a decision or something like that. They need to review. Okay. So those are all of the things, or the main things you need to know about involuntary treatment. Any questions? Okay. So we'll go now. These questions, because remember this exam is from 2013, and I think the mental health laws changed in 2014. So there's a lot of language in here that you might not recognize and that you do not need to know. So please don't go looking it up. What is more important is that we talk about what you might actually do if that question came up again. Okay. So we have a 37-year-old man. He's had a 12-year history of schizophrenia. He's being case managed with a CTO, so community treatment order. He hasn't kept 2 appointments, and his neighbors are complaining about the stench from the rubbish, which is accumulating outside of his rented flat. So what do you think we need to do? Okay, so CTO is not parole, first of all. Okay, so you'd call so we'll talk about police soon.
Criminal scum.
But police would be called when there's an imminent risk to their life or somebody else's life, which is not present in this question. Okay. Now, going back to this timeline, remember I told you, you can change a CTO to an ITO. Okay. All you have to do is you need to tell the Mental Health Tribunal about your decision. So in this case, we know that this patient is likely deteriorating. And remember, we said deterioration is one of the indications for involuntary treatment. So what would probably happen in this situation is that we convert him from a CTO to an ITO. Okay, so we go from a community treatment order to an inpatient treatment order so that we can bring him into hospital. Okay, now for this question, I am not 100% sure if you need to get an assessment order or not. I don't think you do because he's already under a treatment order. So in which case, probably the best answer would be yeah, there you go, revoke, yeah. Revoke the community treatment order. And again, don't worry about this. Say again?
Difference from revoking and placing on an involuntary treatment order?
Well, I think
We're revoking the CTO to make an ITO, which is an inpatient treatment order. So remember, like this is why I put this little dotted line here, because you can change in between the two. So you're revoking it so that you can do an ITO.
where I interpreted it was that like the ITO was like for someone who's new.
Oh, okay.
Rather like he's got on nothing, anything wrong with the ITO. Whereas he's already on the CTO, so you've got to revoke that. And
Yeah, that
then
makes
revoking it, like,
Yep.
goes straight.
Does that make sense? And again, please, I tell you,
Said very from community treatment to involuntary. When you say before, I think it's completely stopped, and that point is kind of like voluntary. But I'm not
We've-
exactly
we've-
sure if that's
we've shown similar questions to Professor Presnell before,
Yeah.
and I can't remember the question exactly, but he has told us to revoke CTO for something before. So in this case, it doesn't mean that you're taking them completely out of the Mental Health Act. I don't believe that's what it means.
Because I remember we had a similar situation where a psychiatrist who wants to change the patient from CDO to ITO, but instead of using the verifying treatment, like from CDO to ITO, she signed a community treatment order with work, which is like supposed to make the patient voluntary.
If you're trying to make the patient voluntary, I thought the wording was like Should it be more discharge rather than revoke?
I'm not sure if it's discharge.
Discharge is
Discharge is more like a point of view.
yeah, you like clear it. So
But
It's
you
involuntary.
it's not the full, I think.
They're all
it's
involuntary.
Well, then why would you put under involuntary order if it's already under an involuntary community treatment order? You have to.
This doesn't stand for. It stands for inpatient, not involuntary.
I'm not sure if you call
I'm saying,
ambulance
like,
first and then
it
have
can't
someone
be
to
I
make
because it's
ITO
already
or
on an
if the
involuntary
community
treatment.
psych services can straight up change it from CBO to ITO.
I think we're thinking too much into it.
Ambulance.
You need to make a decision before you call the ambulance anyway. And the ambulance you'd only call if you have cause for needing them to be transported.
No, Taha,
Yeah, he
what
needs
I
to
was
come
trying to
in,
say was,
So,
He needs to come in.
but you need to change his mental health criteria first.
yeah,
That's what I'm
that's what I'm
saying.
trying to say. So if the community treatment order is involuntary, it can't be I because he's already under an involuntary treatment order. See, I doesn't make sense because he already is under an involuntary treatment order. It's just
What I'm saying is changing from. I'm saying we're doing this, okay? We're changing him from a community treatment order to an inpatient treatment order, so that we can get him to come into hospital.
Yeah, that's what I'm saying.
And to do that, you need to revoke the
I'm
CTO.
agreeing with you.
Which
I'm just saying that, like, for what other people are saying, it's not that one because he's already on that one.
okay,
Like, if you go back and look at I, which says placed under involuntary treatment order,
okay.
he is under an
Yeah,
involuntary.
he's
treatment
already
order,
in.
So you can't do it because he's already under it.
Yeah. So look, I can't go more into this. I'm not. What I know is that this should be correct. That is the concept that we're trying to find the answer to. Okay, we'll leave it there. Okay, go on to the next question. Okay, so we have Rose. She's 77. She's been giving away her most prized possessions to friends and family. And when confronted, she says she can't put up with her chronic pain anymore and plans to take some sleeping tablets and put a plastic bag over her head. Ugh. She asks you to provide a prescription to her not to tell anyone, promising to wait until tomorrow. And when you won't do this, she wants to know how painful it is to die of liver failure. She will not accept your offer of a hospital admission. The manager of the facility where she lives asks if she can be admitted. What do you need to do?
Call.
AO, good. You need to do an assessment order, which in this case will probably be complete the request. Okay, assessment order.
So how's that been with pricing the number?
Because when they're under an assessment order, they are not an involuntary patient yet.
The next.
Yes, that's the next step. Okay. And it says what we said before is called an assessment order because the authorized psychiatrist is trying to make the decision whether this patient needs to be involuntary or not. Do people understand that distinction? There are voluntary patients who volunteer to be treated under the Mental Health Act, but the Mental Health Act was made for people who need to be involuntary. Okay. Does that help?
Is
Okay.
complete request similar to AO?
Remember, please don't look into the terminology
Yeah.
because it would be different. A complete request from that previous lingo should be the same as complete request to get them assessed. Okay, AO. So Michael, who is 72, has dementia of moderate severity, cooperates with carers, has been paying bills inconsistently, does not have a power of attorney, and sees no need for one. What does he need? Administration. Good. So he needs to go to VCAT. So Mavis is 72. She was admitted last night as an involuntary patient. Okay, that's important. On the review this morning, so she's already been reviewed, she remains insistent that she would be better off dead and that no treatment will help. And she acknowledges that responding to treatment when previously depressed, which rules out ECT, okay? So she was admitted last night, so she's already had an assessment order. She's already been reviewed by the Psych, okay? And now what does she need? She needs a TTO. Good. So Mark is 63. He believes his neighbor is torturing him with a black box, so. He does not accept that it could be due to an illness and doesn't want medication. He plans to confront his neighbor tonight with a rifle. What do you need to do?
Police.
Police. Good. That's police. Okay.
Technically,
So-
call police for everything.
I didn't have the energy to read this whole document, but there is a document about using the police in mental health. And if you want to look that up, just, I guess, type that into Google and it'll take you there. So in regards to transport, a psychiatrist or psychologist can ask police to assist with transport with people who have mental illness when they pose a serious and imminent risk of harm to anyone. Okay, so there's that. And you can use sedation if it's unavoidable. So much like the Mental Health Act, there's a lot of lingo about what is avoidable and unavoidable. And they can also help you apprehend people for an AO. Okay, now what is an urgent situation? So you can ask police to attend if there's a genuine and immediate risk of self-harm or injury to anyone. So in that situation, you can't just assume that he's not going to take his rifle and go to his neighbor's house. You must assume that's true. So you need to call the police. He's causing damage to property, which he wasn't, has committed a criminal offense. So, be reasonable. If he's jaywalking, you don't want to call the police. And
that is a criminal offense.
you know his history and you think that the police are needed in that situation. Okay. So that was just a quick, when I just skimmed the document. Okay. So we have a young man. He is being treated for psychosis. He has a hoarse voice, inspiratory wheeze, and appears distressed. What does he need? Benztropine. What is the diagnosis? So it's an acute dystonic reaction. What is another diagnosis if it wasn't a psych paper? No. Yes, anaphylaxis. Make sure, please don't forget that, okay? Somebody who's just been treated with medication and is now presenting with hoarse voice, please don't forget anaphylaxis, which is the first thing I was actually looking for before I realized it was a psych paper. Okay, so benztropine. So again, this is from a Queensland ambulance service. It actually has such good stuff. But these are different types of presentations for acute dystonia. Because the reason I've put this here is because acute dystonia, you wouldn't think that it would affect the mouth. Because an acute dystonic reaction, by definition, is an involuntary, sustained, repetitive muscle movement that is painful. Okay? And that's different to something that is different to akathisia. Do people know what akathisia is?
It's really just restlessness.
Okay, how would the patient describe it to you?
Can't sit still.
Can't sit still. So they always have the urge to move. So acute dystonic reaction is not voluntary. You can't help it. Your movie just moves on its own. It's not an urge. Your body just moves. So there's different types of acute dystonic reactions. So ocular gyrate crisis. We have laryngospasm, which he probably has had. Okay, and that is a medical emergency, and you need benztropine there quickly. Opisthotonus. Okay, there's lots of different things. So there's a lot of different ways that acute dystonic reaction can present. Okay, so we have a 54-year-old man. He has spider nevi, peripheral neuropathy, raised GGT, and he needs surgery. So what is the concern? What is this question trying to ask you? What is this question trying to? That he's alcoholic, okay? And at least this time, instead of just saying he's homeless, at least they've put some reasonable evidence that he's homeless, that he's an alcoholic. Okay, so if he's alcoholic, what do we need to do? Diazepam. If I was in hospital, what else do I need to do? What else should I fill in? Is there a piece of paper? An alcohol withdrawal scale. Okay, and diazepam is also important. Okay, next one, we have a young man. He has type 1 or potentially type 2 diabetes. He has social decline. He's had auditory hallucinations and persecutory delusions. He appears unwell and he wants some treatment. So what would you give him? So what is the consideration that we need to take into account here? Diabetes. So we need to have the one that has the least metabolic effect from this list. So what would you choose? So first of all, so let's go on to the next slide. So this is our list of medications. First of all, identify for me which ones are the antipsychotics. What else? Say loudly. What are antipsychotics? Hello? And? Alans? Okay. Okay. So those are antipsychotics. Okay. Now this list here is all of our indications on ETG for psychosis. So we're going to see which medications match up. So we have 2 on this list. Okay, olanzapine and risperidone are both first line for psychosis. I mean, there's always a few considerations with some of these other medications, but just simply first line medications. So then the next thing we need to look for is which one has the least metabolic effect. Which one?
Hello?
What was the point of? I just put that there because those are first line medications for psychosis, right? Okay, first line medications. Haloperidol is not a first line medication. So risperidone, okay? So the way we know that, other than just knowing it, I guess, colloquially, if we have a look at this paper, so So this is a Cipriani paper, which is the comparative efficacy of many different antipsychotics over many different side effects. It's one of the biggest papers. It's a huge meta-analysis. And if we look at this paper, what we can see is that risperidone has a much lower effect on weight gain than does risperidone. And that's important because gain of weight increases insulin resistance, which would have a direct effect on your diabetes. So that's why risperidone is the best answer for this question, not haloperidol. Okay, so we have a 44-year-old. He has a 9-year history of multiple physical symptoms, dizziness, nausea, palpitations, and chest pain. And he has previously used alcohol to control, and he has found that he can no longer control his alcohol intake. Okay. What do you guys think the answer to this question is? Why do you think that?
I think he might be having panic attacks, maybe it's panic disorder.
Yeah, so I agree with you. So I think what this question is trying to point out to you that this patient has likely got anxiety type symptoms. As you can see here, he's got somatic anxiety symptoms. He's got the dizziness, the nausea, palpitations, the chest pain. He's been using alcohol to try and remedy that. And the first line indication for anxiety is an SSRI. And on this list, that SSRI is escitalopram, which is why that's probably the answer. Okay. So next question, we have a 33-year-old woman. She has depressed mood, sleep disturbance. She can't enjoy time with her baby. She has weight loss, and despite social support, she's still unwell. So what is her diagnosis, likely? Postpartum depression. Okay. And what medications would you use for depression? Okay, so first of all, tell me what's on this list that I can consider. Escitalopram. What else? Mirtazapine. What else? Venlafaxine. What else? What else can I use for depression? There's one more on that list. Mianserin. Does anybody know what mianserin is? That's a TCA. That's the third line. Okay. So third line medication I don't want to use. I don't want to use venlafaxine because that's second line. So I'm left with escitalopram and mirtazapine. How do I choose between those?
Significant weight loss, so you want to regain the weight of the
And what else? So I want to increase weight. So I want to have a gain of weight. And what else does mirtazapine help with? Sleep. Okay. And therefore that implies what time of the day do you give mirtazapine? At nighttime. Okay. So mirtazapine. So it's one of only few medications that you give at nighttime. What is a medication that you definitely don't want to give at nighttime? Because it causes insomnia, it can cause nightmares. You might give for somebody who has an acute exacerbation of asthma, for example. No, prednisolone. Certain beta blockers can also give you nightmares, but what I was trying to get at was prednisolone. So prednisolone can give you insomnia. So that's why you never usually want to give it at nighttime. Just an interesting fact. Okay, so a 15-year-old girl, she has irritable mood, excessive sleep, and school refusal. She doesn't want to put on more weight, so she wants to stop treatment. What was she likely started on? Mirtazapine. Okay, so this was in a different question set, so it wasn't in the same question set, so it's reasonable to be a same answer. Okay, so a 32-year-old female, she's previously well. She is experiencing fluid retention, and she's had a mood disorder in the past. What is she likely on? Lithium. Okay, so side effect of lithium. And this male, he's been treated for mood disorder, but he has difficulty ejaculating. Escitalopram, as we know from that list, is a common side effect of SSRIs. Okay. So okay. So if it makes you happy, we're going to go through these next ones really quickly because it's just.
Stop being restless.
I really need to go to the bathroom.
You go to the bathroom, please.
That's okay. So we have a 50-year-old, and he feels that he hasn't achieved any of his goals. He was retrenched 18 months ago, and he's complaining that life is passing him by, that he's a total failure, that he's never succeeded at anything. So what do we call this? We call these maladaptive thoughts. And how do we solve those? With CBT. Okay, so Rachel, she's 32 and she's distressed and anxious, and just like she recalls her mother being, and she always thinks about her mother because her mother made her feel distressed and anxious, or maybe she was Her mother was unpredictable and manipulative. She doesn't want to become like her. She threatens to take overdoses. So she has a lot of issues that happen at the start of her life. So what kind of psychotherapy helps with that? It's the one you see in the movies where the patient is sitting on the couch and the psychiatrist is sitting next to them. What's that called? Inside oriented. So inside oriented is just like what you see in the movies, and that's for early childhood experiences. You want to get them out of your system, and you want to develop techniques to help you deal with those memories.
Can you argue that she must be borderline?
I can't see how. Because there's a very clear time link between what she's talking about, and there's no other symptoms there.
But is that most of borderline cases from early childhood trauma?
Yes, but it might be, sure, that might be the cause, but there's nothing in here that suggests that she's borderline. Okay, so Miriam, she's 67, and she is 6 months after relapse of schizophrenia, but she doesn't know how long she needs to be on the medication. So what do we need to do for her? Education, so psychoeducation. We have a young woman. She has a long past history, of erratic, impulsive behavior, self-harm, about to be discharged from hospital, and is open to see a counselor. What does she need?
Self-help.
DBT. So she needs dialectical behavioral therapy. I'm not sure what that actually is, but
Stop thinking.
so Alex is 42, and he has a past history of violence, property, and people. He took an overdose of his sleeping tablets when she threatened to leave him after he broke the front door of the house in the course of an argument. What does he need? Probably a crisis intervention. And I'm not actually 100% sure what a crisis intervention actually entails, to be honest.
Basically like a cat.
How does it differ from a cat team then? Do you know?
I don't think it does. I think that is a crisis.
I think
Okay.
just like feeling like a simple thing, so just to calm him down. So it could be very short, or it could be very long.
Okay.
Like a cat.
Okay.
Yeah, crisis intervention is basically a quick review of like whether this person is an inpatient like assessment, like inpatient needs to be admitted under as an inpatient or not, or
Right.
reviewed as a cat team.
Okay. Very good.
Does that mean crisis intervention like go to response for anyone?
Oh no.
Who basically at risk of like self-harm or other people having other people.
Don't look at that.
Can you
So
go back?
clinic soul.
I didn't animate it, it turns out. Don't read that. Okay. So we have a 42-year-old man. He has recurrent psychotic episodes, and he's previously presented with persecutory delusions that have religious themes. Now he presents highly aroused, irritable, and sexually disinhibited. First of all, what diagnosis would we give him? What would his reasonable diagnosis be? What's he presenting with? What is he? Whoa, big boy! Okay, Kirby helped me out a lot with this question actually. So what would his diagnosis be right now? You currently manic. That's what I'm trying to get at. Okay, so acute mania maybe, or an acute psychotic episode. Okay. Now, what do we know is usually first line for an acute psychotic episode? So we'll look at prompt. Okay, so prompt tells us lorazepam or droperidol, depending on the severity of the psychosis, and there's a psychosis sort of benchmark in that same document, which you should read. Okay, but in the same document, it tells us, and I'll now get rid of all of that, that you can, in some situations, that's from ETG from here. So if a patient cannot be physically restrained to the point where an IV line cannot be established, then the intramuscular method is appropriate. And in those cases, you can use Zuclo. So the answer to this question is likely Zuclopentixol.
It can't be decanoate though, because the
It says directly in prompt, that is Zuclopentixol.
Zuclopentixol acetate, which is the short acting. That's the
Yeah,
active
so we're talking about that. It seems like I'm assuming they made a mistake.
Yeah, because acetate
Going for
is on ETG. That's 100% correct, which is what I've got here. But if you read the prompt document, it does cite the decanate, which Kirby very kindly found out for me.
No, it said acetate in the prompt as well.
Didn't it say
I just
decanate?
think they made a mistake here. This makes sense.
Okay.
Decanoate is the depot form of Zuclopentixol. It's essentially what they use for psychotic patients for long-term therapy.
Yeah.
So yeah.
So this is a key mania. We go with like ETG guidelines to treat that, or we just go with
He says risperidone constant, and in
what's that mean?
so constant is your depot form. So if you were to use,
Oh, is that right?
What
Yeah.
options do we have?
Not much, like, in terms of medication, it's very done, or it's.
That would have changed the answer.
As for ETG versus prompt, I don't know. That's a really hard question to answer. I don't know for Psych. I know for GP it would definitely be ETG, but for Psych, probably prompt because Ian Personal has written some of the prompt documents. Because I looked up his name directly on prompt.
Personal mentality.
Okay, so we have somebody who's 32, they have schizophrenia, they discharged 1 month ago, and they were successfully treated. Now he lies awake in bed during the day, only gets up reluctantly to eat and drink or to go to the toilet. He seems quite depressed. So what do you give for depression? Acetylpram, probably acetylpram.
You don't argue that he's non-compliant with his medication?
But he says that after successful treatment with olanzapine, which would imply to you that he's continuing to take his medication.
Olanzapine would make you sleepy, but he's lying in bed. Yeah.
Well, that's true. What do you think?
I think you're right though.
Or maybe like
And then the
negative.
rest is just negative because it's the prodromal phase of.
I mean,
And if he's on olanzapine, doesn't explain why he's reluctant to eat because
That's maybe you have three.
He's probably just depressed.
Yeah, that you have decreased appetite in depression.
yeah, but is that really
Olanzapine
decrease
makes
appetite?
food in that cup.
What would you suggest as the answer?
Experiment concept.
I think that's very reasonable.
Yeah.
Because olanzapine,
It's fine on
yeah.
you're not going to go on constant until you've done risperidone oral to prove that it works for them. Straight away.
he's reluctant to eat and drink. I can see why you consider giving him diet.
Usually, if a treatment's working, you don't change it.
You don't switch it.
Yeah.
I thought he's depressed.
I'm not convinced.
That's what I thought. So that's what I thought as a telegram, but I take your point. But like Kirby said, you don't usually change medication. Okay. So Mitchell, 42, has lung cancer, requires oxygen all the time. He's trying to make the most of his time, but struggles some days, especially after his children visit. What do you think he needs? Supportive therapy. That's what I think too. Okay. And then Amanda, she's 17. She's living with her parents, goes out to parties at the weekends, drinks until she passes out. She can't remember what she done, doesn't seem concerned because all her friends do the same thing. She argues that she works hard during the week and at her part-time job and deserves some time off. So she's having some discourse between her parents. So what do you think she needs? Some parent therapy. Parent therapy.
What is family therapy?
Family therapy, usually in relation to when somebody's been diagnosed with something. And
Family based.
Yeah.
Yeah, so with someone who died.
No, I think it's really specific to eating disorders. Family therapy is more like.
when you have family discourse.
Family discourse.
Usually when there's like younger children and the parents might have been going through a divorce or something. So then you need to try and explain that to the children and make sure that they're getting the proper support and stuff. Whereas this is pretty specific for discourse between parents and child. Okay, next question. Fiona, she's 37. She has MS, confined to a wheelchair. She's arguing more with her husband and struggles to deal. She needs relationship therapy. Correct. Ian has always hated needles, and now he needs to take needles. Desensitization. Okay. A 45-year-old plumber has become depressed, and he misses a lot of doses of medication. So what do you need to do? You need to educate. Oh, yeah, true, actually. Is that on the list, though?
What did
No,
you say?
sir.
What was it?
Okay, motivational interviewing would be a very reasonable answer
If it was there.
if it was there, but in this case, he needs to be educated. Okay. So Michael, 15, took an overdose
Oh, you were trying.
when his, oh, there you go, it's right here. When his mother and Phil announced they would be getting married. He normally gets on well, but he always hoped his parents would get back together even after they're divorced. So what did they need?
Family therapy.
I swear I didn't realize that question was there. Family therapy is there. 97. So we have a 67-year-old lawyer. He's admitted to hospital for pancreatitis, confused, nystagmus, short-term memory impairment. What does he have? Wernicke. So therefore he needs thiamine. Okay. So if we were to look at complications of alcohol toxicity or alcohol withdrawal in the acute, or just alcoholism in the acute and chronic setting. So acutely, delirium tremens is what you'd get. And the mnemonic you can use to remember the symptoms would be death. So delirium, autonomic or overactivity, so you get sweating and the such, tremor and hallucinations. So hallucinations are usually maximal by, I think, between like the second and third day. Okay, and you should look into the proper management for it, but just simply diazepam, admit them, make sure that they're well controlled. Okay, Wernicke-Korsakoff are two different entities that often occur together. So Wernicke is a reversible condition, okay, where you have the nystagmus, ataxia, and encephalopathy. Okay, so it's damage to mammillary bodies, and mammillary bodies are implicated in memory function. So that is why you get the memory dysfunction, and that's why it's associated with amnesic syndrome. And then Korsakoff is when you have severe short-term memory deficit, which is a continuation of Wernicke's, and you get confabulation. So that is another thing that is unique to Korsakoff syndrome. So then last one, second last one, 34-year-old male, schizophrenia, treated under a CTO, and then he is increasing belief that he's being controlled by his older brother, who's trying to make him suffocate his elderly mother. What do you think needs to happen here? Yeah, that's what I thought. So I thought there was two possible answers to this. One was potentially police, but I don't think there's clear evidence that he's going to harm someone. But what you could also do is, as we talked about the last question, revoke the CTO and do an inpatient treatment order. Or maybe you could call the CAT team. I'm not 100% sure what the answer to this question would be.
I think the first cat is
Doesn't the CAT team admit them to, they assess them and see if
They might, yeah. But I think like that. I think like in this situation, I'm not sure which one is the most appropriate option.
Given the potential urgency of the
Cat team?
situation.
Because clearly he hasn't suffocated, like made an attempt to suffocate
Okay.
the elderly mother.
So we'll say CAT team. Oh, actually, no.
Technically, if you're under
No.
CTO,
Yeah.
is there any point
Yeah,
of
that's what
calling
CAT
CAT
team
team?
is.
Yeah. So I was going to say, so the next question I thought was something that will make this question easier to answer. So we have a 28-year-old. She has frequent episodes of self-harm, presents with increasing hopelessness in the context of her therapist being on leave. And she has thoughts of taking an overdose of antidepressant, but she does not want to do this. So this one, I think, would be referred to the CAT team. I actually asked somebody who was on the CAT team, and they thought maybe that was a reasonable answer. So I think revoke the CTO and make an inpatient treatment order. Okay, so last question. We have a 30-year-old male, mild depression, alcohol abuse. He attempts to bash and kill his ex-partner. What do we need to do? Call the police.
Okay, fine.
Okay. Okay, and then so these last few slides are all available on the mixtape. I've put them in there because we haven't done much Psych, and maybe looking at these mnemonics will help you to remember it. So this table, what it's meant to do is to help you structure while you're doing your reading time if you're very lost. So in your Psych OSCE stations, if you're lost on what to write, you should just write the mnemonics for all of the conditions so that when you're actually in the station, you can very quickly just mark them off. So in any Psych history, you always want to ask about the history of presenting complaint, like any history, if they have any past psychiatric history, and then just do your roadmaps assessment, which is your risk assessment. So ask all of these questions, organic causes, as we talked about, then alcohol, drugs, medication, then, all of these mnemonics. So there's lots of mnemonics here that are all thank you to Cecilia Zhu, who's our senior, who made all of those mnemonics on the table, which I use so much. They're really, really helpful. So big thank you to her. And then at the end, don't forget family history, their personal history, and their pre-morbid personality. So how were you before you started to get sick? So I'll just leave that there for your reference if it ever helps. Thank you again very much for coming. We'll end it there. And next week we'll do something, hopefully. Okay. Bye, bro.